So prior to inserting a cannula, we need to get our trolley, which will be the clean surface. We need some equipment, so a dressing pack, our goggles, apron and gloves, and a tourniquet. And we come to Catherine and we position Catherine such that she is not in danger of falling over or fainting or hurting herself during the procedure. And we're going to then do a risk assessment on the limb and also, of course, get consent. So first off, Catherine, have you had a cannula before?
Yes. You
have. So you know that it does sting a little bit on the way in? Mm-hmm. Yeah? Okay. And once the cannula's in, because the doctor's asked that you have antibiotics, once the cannula is in, we're going to be looking at that site regularly to look for any swelling or if there's any pain. Again, you let us know, but we'll be checking this on a regular basis.
Sure.
Okay. So we do a risk assessment to ask if Catherine had had a mastectomy or a stroke or was a renal patient. With renal patients, we would consult with the medical officer. If there's any swelling or any infection, bruising in the area, we would not use that limb. Then we need to decide where the cannula is going based on the need of the patient. So if Catherine needed only things that were not thick, not irritating, not fast, we would start distally and work our way up. If they're going to be thick or irritating or fast, they need to be in a larger vessel higher up on the limb. We try and use this area here in the cubital fossa for emergencies and for blood taking if possible. So for today, Catherine, we're going to be looking at using the cephalic vein. I've gelled my hands and I've come back now with a single patient use tourniquet, putting the tourniquet 10 to 15 centimetres above the site. And we're going to have a nice firm tourniquet. And we can see here that Catherine has a lovely cephalic vein here. And if Catherine had, if Catherine was a male and had a lot of hair, we'd need to clip that site. If Catherine was dirty, we would have needed to have cleaned this site before this. But I can feel that that's nice, soft, bouncy. It's not hard, it's not cord-like. And as you can see, you can visually see the vessel. So we need to look also for landmarks, and I can see that there's some freckles nearby, but again, Catherine's vein, I can see it without looking for landmarks. Some places use skin markers where they mark above and below in case they can't see the vein. If I could not see the vein well but could feel it, that is my decision then that I would have to use sterile gloves when I come back because I would need to repalpate. With Catherine's vessel now, I can put normal gloves on because I will be able to see that vessel quite easily. So I've released the tourniquet now on Catherine. I need to open up my packs and equipment. So I'll gel my hands again and we'll open up the new packs that we have for the health service. And in the pack, you will find that there's an inner pack. Now I've cleaned the surface of the trolley obviously before we've started, and we'll open up the pack onto the surface. And in this pack you see that we actually have a bluey that we can put down under the patient's limb. We have some gauze we can use in case we need to wipe the area of blood, and certainly there's a dressing. You'll find also in the pack we have our PosiFlow normal saline flush, so we'll empty that onto our general field. We'll also empty our extension tubing because we're trying to put extension tubing on all new cannulas, and that just preserves the life of the cannula. Also then you'll see that we actually have a swab stick, and this is the chlorhexidine to prepare the site. We also might get some tubey grip to have available as well to put over the cannula once we've finished inserting. My PosiFlush and my extension line, I'm going to prime it. And so we'll take the cap off and we will attach and prime. And leaving the cap on, we'll sit that in place. We also need to put our cannula onto the surface. We don't encourage taking blood from new cannulas due to the risk of hemolysis and hemoconcentration, but if you do take blood from a new cannula, you also would have your 10ml syringe and a transfer device and some blood tubes available in this setting. I'm now going to put my goggles and apron on, and we're now going to go and actually prepare the site. So just lift up in, please, Catherine, up your arm. Thank you very much. And we're going to get our swab stick now. I'm going to clean the area. So let's turn your hand aside here. And we ask, of course, if someone is allergic to chlorhexidine or not. Circular motion, working our way out. We're now going to let that dry for 45 seconds. I've now washed my hands again. I've decided to use non-sterile gloves because I thought I could see Catherine's vessel quite well. We'll come back to the patient and we need to do the tourniquet up. If we had sterile gloves on, we would have to have another person do that tourniquet up. I can't repalpate that site now though because I do have non-sterile gloves. And so now we're up to the point where we're going to grab our cannula and make sure that we spin the hub 360 degrees to unlock the plastic from the metal. And now we're right now to anchor the vein. I'm going to anchor the vein and we're going to insert at a 15 to 30 degree angle. You can we've now come to the point again where we're going to anchor the vein. So Catherine, it's going to be a little bit of a jab, and we're going to enter at a 15-degree angle. We would get flashback up the shaft of the blood control cannula. We'll decrease the angle in a tiny bit further, and then either push off with one finger or two. Now at this point, because they're blood control cannulas, we will release the tourniquet, and then we can actually push the activation button, and no blood will come out for 10 to 15 seconds. We then, of course, need to grab our flush, and we need to hook up our primed flush, and we could do push pause, push pause, push pause, push pause, and actually flush the cannula. At this point now we need to do some dressing though, and so the new dressings that we have, we would then be taking the cover off and then just applying the dressing around the site. And then from there we will take the extra, so stop. We've put the dressing on, we've taken the outer edge off, and this extra part can go over the hub of the cannula. We would then use some further micropore to actually go across to make a loop. This would be signed, this would have inserted on and the date actually written on it, and that sticker is going to go onto the actual dressing itself, so we can see. So we haven't already finished flushing with push pause, and right near the area at the very end, as you're pushing, we would clamp off. We would use the whole 10 mils to flush this IV cannula. So again, this would loop, we would pop some tape across here, and we might hook up to an IV therapy, or it would just be a bung. We can use some tubey grip to put over this side if we wish to, just to keep it all together. We are going to have to look at this side at least 8 hourly because it's just a bung. If it was hooked to an IV, we would have to look every hour at the side. Documentation, we will use stickers to document in the patient's chart, and also on the care plan we will document. So from here, this tourniquet is a single patient tourniquet. It will remain with the patient at their bedside. And then as far as the care and management of the cannula, we'd have a discussion with Catherine about let us know if it becomes painful or if there was any swelling, if there was infusions running through. We will of course look at this on a regular basis. We'd also talk to Catherine about going to the shower, that we will need to put a cover over it for a shower.